I would request Dr. Soumya Nambiar, consultant pediatric ophthalmologist from Comtrust Eye Hospital, to give her talk on corneal injuries in pediatric patients, do's and don'ts. Over to you, Doctor.
Good morning, all. First of all, I would like to thank KSOS and Dr. Lakshmi for having given me this opportunity. So, corneal injuries in adults, as such, is a challenge, and pediatric corneal injuries is furthermore. So, let's see how do we manage. I'm going to talk.
Have a bit of silence, please.
I'm going to talk regarding my presentation under the following headings. So what is the, why do you need to know about pediatric corneal injury? First of all, in a pediatric corneal injury, identify which type of corneal injury it is.
It would be greatly appreciated if you
identify the problems which are seen in the pediatric age group, and what are the main do's and don'ts that we have to think as a general ophthalmologist in managing a pediatric corneal trauma. So when you see that whenever a child comes with pediatric trauma, we know that the most common, it's one of the leading cause of non-congenital monocular blindness in children. And eye trauma constitutes 7% of all bodily injuries and 10 to 15% of all eye diseases. And this is the incidence which you see, and you can see that India is somewhere in this range. And this was a paper which was seen in conducted in a tertiary eye care in central India. And as you can see that among the pediatric trauma cases, most of it were the males that were, the boys were more commonly involved, and the lower socioeconomic group was more involved with injuries. Till now, an adult ocular trauma score by Kun et al. Was being followed. So as you can see that each of the trauma like visual acuity, globe rupture, and endophthalmitis have been given certain points. But a pediatric trauma score was not there up till last few months and few years. And the problem with pediatric trauma is that you cannot check the visual acuity in a child as you can check in an adult. Plus, in condition like an RAPD, which you can do it in an adult, it's not easy to check in a child. So that was the importance why a pediatric ocular trauma score came up. And as you can see that all the points that have been given, can I have a pointer, please? The points that have been given, as you can see on the right-hand side, the points are reduced when compared. Yeah, you can see these points. Their raw points are reduced for the pediatric cases, okay? And higher the points, it is presumed to have a better prognosis. And you can see that here, age is given a criteria, not like the adults. That's because in adults, as I told, visual acuity is given importance, RAPD is given, but in pediatric cases, you have to look at the age, and that determines. The lesser the age, the prognosis may be bad. Now, when you're dealing with corneal injuries per se, what you have to know is that these could be a closed globe injury, it could be an open globe injury. The simple corneal epithelial defect, a corneal aberration, a corneal chemical injury, a lamellar corneal tear if it is partial, or a full thickness lamellar tear or full thickness corneal tear can be there. So problem with a pediatric patient is one of the things is that it's difficult to examine the children, and you may not get a proper history, okay? And therefore, you need to have a very keen observation. Like as you can see in this child, the child has a very low blink rate. So you know that there's some problem that is going on. And as you see, the child is crying, and you can see the child is actually having a facial nerve palsy, okay? So such children, when the blink rate is less, there's a chance of foreign body injury, the response may be a little bit less. So in pediatric cases, the thing that you should remember is a small infection can progress fast, and therefore you need to act fast. A delay in diagnosis increases the risk of endophthalmitis, and because the pediatric eye is a developing eye, the chances of amblyopia is even more higher, and the need for general anesthesia, though that is one of the factors which will cause a problem for giving a first-hand treatment. And as a primary care physician, what you have to remember is that as a child walks into your clinic, you have to take a thorough history, because through history itself, you can gauge that probably this child is having a penetrating injury, or maybe the child is having just an epithelial defect or a foreign body. And you have to ask where this incident has occurred. And any medico-legal issues, like battered baby also can be there. You may not get the history in the initial stages, but later on it may come, and you have to see that you have documented everything. And remember to observe, like supposedly there is watering, there's difficulty in opening eyes. You have to think why, and then look and hunt for it, okay? So I'll be dealing with each of these in this way. First is a corneal foreign body, which is the most common way that they can present. Remember, in a pediatric case, or for that matter, any foreign body, you have to do an eversion and a double eversion. And if it is a superficial foreign body, if it is in the palpable conjunctiva, definitely you can remove it even if it is a kid. But if it is deep, you may have a rust ring associated with it. You may need a scraping. That time you may need a anesthesia for the kid. Look out for vascularization, especially if it is an old foreign body. This is very common in children, and sometimes infiltration also can be there. So you may need to examine the child under microscope, under a sedation maybe at least. The second scenario is a chemical injury. It could be acidic or alkali, and alkali is the most common. And as we do, usually you give at least a 30-minute wash till the pH is altered. But remember to remove all the particulate matter from the fornices, avoid the conjunctiva, remove the particulate matter below the palpable conjunctiva as well. And remember that tap water is found to be more hypotonic and may tend to increase corneal edema. So if you have BSS, that is more preferred. The third thing is corneal aberration. So whenever you have aberration, you have to rule out penetrating injury and then only stain the cornea. And you can see, depending upon the stain, you can localize if there is any foreign body also, okay? And if it is taking up the stain or not. And as I told, stain only after ruling out penetrating injuries, okay? Then as corneal penetrating injury. Now it could be a full thickness with foreign body or without foreign body. And if preoperatively, whenever you get a penetrating injury, history-wise, history is very important. If at all there is a history of a high velocity traumatic injury, always suspect a penetrating injury, even if you're not able to examine the child. And if doubtful that it is a full thickness, only if you are doubtful that it is not gone full thickness, only then do a Seidl's test. You can do a full Seidl test to see if it is negative or positive. And whenever you find a foreign body, do not attempt to remove the object. And any subconjunctival hemorrhage, you need to explore and see for any extraocular muscle or scleral tear. And as a general ophthalmologist, always tell the child to be on NPO, start systemic antibiotics, give a GVP, and explain that they may need more than one surgery. And always record whatever you have done. And the goal of corneal surgery is same, tight suture. These are the videos which Laila madam has given. You have to take a culture from the wound site, remove the exudates overlying it. Always look for other injuries. You may miss out all these, okay? So open the conjunctiva in the corresponding area and look for the tear. And use lot of viscose and see that the iris is not adherent to the site of your wound. And if at all possible, do a paracentesis and from that site release the iris. Always bury the suture. Do not leave anything unburied. At the end of it, do a Seidl's and confirm that it is tight. And if possible, take a IOL calculation, do a fundus examination also, okay? And in the late stages, look for the suture strength, do IOP monitoring, look for vascularization, and definitely do a amblyopia treatment. And always prevention is better. Get an ocularist opinion, and especially in a one-eyed children, you have to wear protective glasses. Tell the parents about it and educate them about it. Thank you.
Thank you, Dr. Soumya, for the extensive